Welcome. Let's talk about strategies to prevent acute exacerbations in COPD patients. This was based on the recent guidelines released by the American College of Chest Physicians and the Canadian Thoracic Society. So let's get started. The guidelines are divided into three general categories: the non-pharmacological or vaccination category, the inhaled therapy, along with pharmacological oral therapies. So the recommended non-pharmacological therapies of vaccination includes the influenza vaccine, but what's suggested as well is pneumococcal vaccination. It wasn't shown to reduce exacerbations, but the presence of strep pneumonia in the airways has shown an increased decline in COPD patients. So definitely the flu vaccine along with pneumococcal vaccination, both in combination, should be part of the regular routine follow-up in patients. Pulmonary rehabilitation is another thing that's strongly advised. Within 4 weeks of exacerbation, the effect of it on reducing further exacerbations after 4 weeks has not been shown. Pulmonary rehabilitation has had a notorious slow start in being incorporated into the standard therapy for COPD due to the high cost of time and effort by the patient to actually get from home to this pulmonary rehabilitation centers. However, nowadays, I think with the advent of telemonitoring and along with health IT, there's some new studies that are looking at remote pulmonary rehabilitation for some of these patients. The other effect as well has been that the sustained improvement seen in pulmonary rehabilitation past the 12 weeks of treatment hasn't really been as good at the 12-month mark. So hopefully with the incorporation of telehealth, we might be able to see better improvements in pulmonary rehabilitation, but generally consider pulmonary rehabilitation upon discharge from the hospital in patients. Now, the next thing that was recommended as well is a combination of education and case management. Education being recognition of the disease process, recognition of lifestyle changes that need to be made. Case management meaning patients being made aware of what resources they have in the community, what resources they have at the hospital for them to help in terms of reducing their comorbidities, along with maybe even providing coupons and so on to reduce the cost of acquiring the drugs. So an education case management combination, and this has to go hand in hand with either a written action plan, meaning the patient recognizes an exacerbation, understands what they need to do. At times, patients can even be given a prescription of a short course of oral steroids along with antibiotic to recognize early on and start treatment to avoid a repeat readmission. And the other thing in combination with education and case management is direct access to specialists. And that's been shown. The earlier you refer a patient to specialists such as pulmonologists, you will see benefits, or it may actually help reduce exacerbations or repeat return visits to the hospital for COPD. So consideration for that as well. So the suggested ones, like I mentioned, is the other thing is smoking cessation. This is notoriously difficult due to patients' addiction to nicotine. However, the best outcome usually seems to be a combination of pharmacological and behavioral intervention. Pharmacological meaning nicotine replacement therapy, whether it's patch, lozenges, gum. Antidepressants as well, such as Wellbutrin XL, may be considered, especially if the patient has a mood disorder, and a lot of the times depression coexists with many patients with COPD. The other thing is nicotine receptor modifiers such as Chantix given over a 12-week period. However, what we found as well is that the longer Chantix is given, the ability for patients to abstain from nicotine smoking seems to have helped. Counseling through behavioral interventions, now whether this is through online psychologists, whether it's a therapist in the community itself versus the 1-800-QUIT-NOW helpline, which may be beneficial for patients who feel at risk of relapsing and smoking again. Now, some patients may have a concern about weight gain related to smoking cessation, especially in women. However, they have to be reassured that the weight gain is a good gain, as they tend to then lose the weight that they initially gained. Some patients may have a nihilistic view of the damage done from smoking. However, they need to be reassured that the damage can be mitigated, the quality of life is improved, along with a decreased risk of developing cancers after that. So those are generally the overall take from the non-pharmacological therapies. Now, just looking at the pharmacological inhaled therapies, it's a little confusing even for me as a pulmonologist. Now, the newest GOLD 2015 guidelines, which is a great read, kind of makes things a little bit more confusing because unlike other years, where we just used a FEV1 cutoff to stratify patients based on mild, moderate, and severe or very severe. The new guidelines incorporate not only a PFT or flow limitation, but they also incorporate functional status in these patients or symptoms, along with exacerbation history. So a patient with minimal flow limitation, but with severe disease process or severe dyspnea, for example. Obviously, in patients with severe dyspnea, out of proportion the flow limitation, you need to consider other possibilities contributing to it, such as cardiac disease, pulmonary vascular disease, and so on. But again, patients not only with severe dyspnea or symptoms along with exacerbations, they may need a change in their medication. So don't just follow the FEV1 cutoff as the way of treating these patients. So overall, the way I look at it is the short-acting beta agonist, such as albuterol, has the lowest role in this, and that helps out with most patients with acute shortness of breath. But what actually helps with some of these patients that reduces exacerbation is the short-acting muscarinic agonist or antagonist, such as ipratropium. So this patient, we actually benefit from a combivent therapy. Combivent, which is the trade name for the drug that has a combination of both the ipratropium and albuterol, seems to help reduce exacerbations. If a patient can afford or can get access to a long-acting medication, it'll be a long-acting beta agonist or a long-acting muscarinic antagonist. This being part of the formoterol or salmeterol group, while the long-acting muscarinic agonist would be in the tiotropium group, or marketed as Spiriva. So those two drugs are recommended if they need long-term or long-acting medications, and this can be used in combination with the short-acting beta agonist. Some patients have also, for example, if they use a long-acting beta agonist, they may use a short-acting muscarinic agonist as well. Now, the combination therapy, which is really popular as well and gaining popularity, is the LABA, or the both the combination of the long-acting muscarinic agent with the long-acting beta agonist. And this as well goes along with the inhaled corticosteroids, LABA and LAMA combination. So that again helps in a lot of these patients. There are newer drugs out now, such as Stiolto, Stiolto, and Ellipta. I hope I spelled that right. Ellipta, which is currently marketed, and it's actually a pretty easy drug to use once a day, so consider that. And by the way, I have no declarations. I wish I did, but I don't receive any money from these pharmaceutical companies. So those are just basically breaking down some of these medications and kind of making it easier for you. So it starts off with the short-acting beta agonist. The next on the list would be short-acting muscarinic agonist. So as you're going up, it's more preferred long-acting beta agonist, followed by a long-acting muscarinic antagonist, and then you have your combination therapy, where there's inhaled corticosteroid in combination. So the inhaled corticosteroid should go in combination with your long-acting beta agonist, not separately. They haven't shown to be as beneficial. So those are the pharmacological inhaled therapies. Now the next portion of it, the last portion, is the oral therapies. Now assuming someone's on the right combination of inhaled therapies and they've been on it for at least 4 weeks, meaning that they're medically optimized and these patients still have frequent exacerbations or symptoms, consideration for long-term macrolides. And this you can give it as erythromycin, and that can be given as 200 milligrams BID, or azithromycin, which is given as 250 milligrams Q daily. And those are the options. These studies have actually shown reduced exacerbations, but there was an increase in hearing problems, increase in patients with colonized. Those who were colonized had macrolide-resistant bugs, but they didn't really translate into worsening respiratory status. So we're not really sure what to do with the data, except the fact that we know that it reduces exacerbation. There's a theoretical risk of QT prolongation as well, and again, I think during the study there was none of these patients was seen to have any problems with that. However, that's always something to consider. Systemic corticosteroids should be started within 30 days. Steroids, whether it's IV or PO, does not make a difference, but it should be started within 30 days. Anything more than 30 days or long-term steroid use is generally frowned upon and really hasn't been shown to reduce exacerbations. So try to avoid prophylactic steroid use in these patients. Next thing is the PDE4 inhibitors. A drug that's currently marketed is Daliresp or Roflumilast. I'm glad I pronounced that correctly. And these PDE4, it's the first in this class, is shown to reduce exacerbations in patients with exacerbation in the last 12 months with the chronic bronchitis type of COPD. However, there's recent studies that show actually that patients may develop resistance. To take note of that. Theophylline is a new, it's not a newer drug, it's an old drug now that's coming back into vogue. You can take that twice a day. Again, it's got a short or narrow therapeutic window, and it interacts with a whole lot of other drugs, so some patients may not tolerate it, or they may need to warn other physicians if they are starting new medications regarding their current theophylline use. But theophylline as well is getting back into more popularity as it seems to be doing a decent job. The other options as well that's suggested is N-acetylcysteine, given as 600 milligrams BID. And the other one is carbocysteine, which is the drug isn't as popular in the United States, but both of these drugs act as mucolytics, but they also seem to have more of an anti-inflammatory, antioxidant effect, which may be beneficial in some of these patients. So consideration for all of that. Currently, there's no recommendation regarding statin use. I hope some of this has cleared up the air about how to use some of these medications and what to recommend in patients to prevent acute exacerbations. You can refer to the ACCP website or the GOLD 2015 guidelines for further details. Thank you.